My name is Lola Aroshala. I'm one of the final year medical students at St. George's. I'm here with Ms. Suruchi Pandey, and she's one of the consultants in obstetrics and gynecology here at St. George's. She's also the lead for endometriosis and our lead for obs and gynae teaching at the university. Welcome.
Hello, Lola.
So today I believe we're going to be talking about abnormal uterine bleeding.
Fantastic. Fire away.
So can you tell me, what does that mean?
So, abnormal uterine bleeding is anything out of ordinary, right? Out of which is not normal. So, to understand what is normal, we first need to understand what a menstrual cycle is like. So, what a normal menstrual cycle is like. So, there's this diagram of the normal menstrual cycle. What happens in each menstrual cycle is that we recruit one egg, which becomes, we call it the dominant follicle. And that dominant follicle secretes an hormone called estrogen. So, because here you can see the estrogen levels are going up, that leads to the building up of the lining of the womb, which is called the endometrium. So, this is in preparation for a pregnancy. So, in the middle of the cycle, this egg, the follicle ruptures the dominant follicle to release the egg. And what is left behind is called the corpus luteum. And corpus luteum secretes a hormone called the progesterone. So the progesterone causes secretory changes in the lining of the womb in further preparation of pregnancy. However, if pregnancy doesn't happen, then corpus luteum shrivels away. And then the lining of the womb is shed, which is called the menstruation. So this is a very simplistic version of the menstrual cycle. But for the menstrual cycle to function normally, there are various hormones that are involved, which is the FSH and LH. There's the GnR, firstly there's the GnRH hormones. Then there is the FSH and LH hormone by the anterior pituitary. Then there are the ovarian hormones. Then also thyroid and adrenal hormones should be normal. And also the clotting in a woman should be normal. So there's lots of systems in the body which need to function in coordination for a woman to have a normal menstrual cycle. So when I say normal, what do I mean by normal? Like how often should they bleed? So any bleeding between 24 to 38 days is normal. The length of bleeding should be less than 8 days. And earlier we used to say the volume of blood should be less than 80 mils. But now we don't use that definition. Instead, what we say that heavy menstrual bleeding is something that impairs a woman's social or material quality of life. So any bleeding that a woman finds distressing, we define as heavy menstrual bleeding. But the abnormal uterine bleeding is not just heavy menstrual bleeding. It can be frequent bleeding, infrequent bleeding, absence of bleeding, inter-menstrual bleeding, post-coital bleeding, and heavy menstrual bleeding. So all of these are a part of a spectrum of what we call abnormal uterine bleeding.
Okay. And can you just explain a bit more about the different types of abnormal uterine bleeding?
So as I said, the most common is heavy menstrual bleeding, which affects nearly 25% of the women of the reproductive age group. And there are various causes to it, which I'm sure you will come later. But what are the other things? One of the common ones is amenorrhea, which is absence of menstruation. It can be primary amenorrhea, that is periods don't start at all, or secondary amenorrhea, where periods have started but stopped. So that's one form. Then there is intermenstrual bleeding, in which the periods are normal, but there's bleeding in between the periods. Then the next is the post-coital bleeding, where the periods are normal, but every time a woman has intercourse, she has bleeding. And then, as we mentioned, periods can be very frequent, and this can happen when somebody is starting menstruation or in perimenopausal women. And sometimes they can happen without the physiological reasons as well. And sometimes periods can be very prolonged, as in the time from one period to the other is almost sometimes more than a month. It can be 2 months, 3 months, And the most common condition when that happens is polycystic ovarian syndrome. So there's a wide spectrum of problems that can happen with menstruation.
I see. And what are the sort of like red flags that women should be looking out for in terms of bleeding, abnormal bleeding?
That's a very good question. So first thing is women should keep up with their smear tests. So if there is post-coital bleeding, that is bleeding after intercourse or intermenstrual bleeding, then that can sometimes be concerning. It can be due to iatrogenic reasons as well. Sometimes taking progestrogens or progesterone contraception can cause irregular bleeding. So it's not always a red flag, but sometimes it can be as a result of lesions in the cervix or polyps inside the uterus, or sometimes even because of sexually transmitted diseases like chlamydia, they can cause intermenstrual bleeding. The other red flag, which is postmenopausal bleeding, that is, menopause is when a woman stops having a period for at least 1 year, and if she starts bleeding again after menopause without being on hormones or HRT, then that is a concern. It needs to be investigated to rule out any kind of cancer of the female genital tract, most commonly to rule out endometrial cancer. So that is a red flag. Also, if what we say perimenopausal women, that is women who have not achieved menopause, who are in the age group of 45 to 51, if they are having irregular bleeding, which there's no pattern to it, then that is a cause of concern and that should be investigated. As I mentioned to you, these women can have frequent bleedings because of hormonal changes, but if there's no pattern at all, then that is concerning.
Okay. And I believe we're going to touch on or focus in more on abnormal, like heavy menstrual bleeding now. So can you tell me just a bit more about specifically heavy menstrual bleeding and how common it is, and what the causes are?
Sure. So unfortunately, it's very common. Heavy menstrual bleeding affects 25% of the women of reproductive age group. Unfortunately, it's more common in the perimenopausal age group, and these problems usually start in women around 35 and then go on till the age of 50. Not all women, of course, but some of them. Now, what are the causes? The causes can be structural. We say structural if they can be identified on imaging, that is by ultrasound scan or MRI, and then there can be non-structural, that is we can't identify them on any imaging. So structural causes are things like lesions in the cervix, polyps, fibroids, adenomyosis, if there is abnormal thickening of the lining of the womb, as it can be in cases of malignancy. So those are the structural causes. The non-structural causes, which you can't see on scan, they can be coagulopathy, things like ovulatory dysfunction, polycystic ovaries where you have infrequent periods, but when you have them, they are very heavy. Then there can be inflammation like PID, when the endometrium is inflamed, we call it endometritis. That can cause heavy bleeding. And there are some rare causes like AV malformations, being on blood thinning agents, having dysfunction of thyroid hormones. All of these can cause abnormal uterine bleeding as well.
Okay. And if a woman is experiencing heavy menstrual bleeding, what can she do?
So if a woman is experiencing, the first thing is to see their doctor, and the doctor would like to do a few investigations. So first thing is, if you are having heavy bleeding, you may be anemic. So you may have iron deficiency anemia, your hemoglobin may be low, and that can make you feel very tired, that can cause hair loss, fatigue. So you should get a full blood count done to see if your iron stores are normal. Then the other thing a doctor would like to do is an ultrasound, and ideally a transvaginal ultrasound. So then you can see the structures like the uterus and the ovaries very clearly. So if there's a structural cause for that heavy bleeding, that will be picked up in the transvaginal ultrasound. Sometimes the transvaginal ultrasound may pick up thickening of the lining of the womb or polyps, and then what is the gold standard is an investigation called hysteroscopy. Hysteroscopy is a very simple procedure in which the doctor goes in, through the cervix, vaginally through the cervix, to have a look at the lining of the womb. And we can also take a sample from the lining of the womb, or if there's a small polyp, we can take it away at the same time. So that is the gold standard. If we need more information, there's an investigation called MRI, which gives us detailed information on things like fibroids, endometriosis, and any sort of malignant pathology.
Okay, all right. And in terms of treatments, what's available?
So first, as you said, rule out the red flags.
Mm-hmm.
So if there are red flags present, then the GP would refer you via the 2-week pathway to the secondary and tertiary care centers, where you will be investigated further to rule out cancer, and then the treatment would initiate. But if there are no red flag symptoms, suppose a patient is having regular and heavy bleeding, then to start with, the GP will do an ultrasound, and if that's normal, then just initiate on medical management, which can be some hormones or contraception tablets to regularize the cycles and to reduce the amount of bleeding. He can give you medication like tranexamic acid, which reduces the blood loss. So these are very simple things which work well for most of the women, and these can easily be done in the community. However, if this is not working, and if we feel that some surgical management can be needed, then there are things like burning away the lining of the womb. If there are any fibroids, then to remove the fibroids. If there is severe adenomyosis and a woman has completed the family, then to do a hysterectomy. Or if a woman feels that she doesn't want any medical option and this is the surgery, she wants the uterus out, that is the very last resort. But there's lots of hormones, contraceptions, contraceptives work very well, that can be given in the community. And one of the things that has changed the management of heavy menstrual bleeding is the Mirena coil. It is a progesterone intrauterine system, and what it does, it thins the lining of the womb, and it can stay inside the uterus for up to 5 years. So this is what we use very frequently to help with heavy menstrual bleeding. But if all these measures, medical measures, doesn't work, then there's a range of surgical measures which can depend on the pathology. So if there's a polyp, you take the polyp out. If there's a fibroid which is indenting the lining of the womb, you take that out. If there's a fibroid outside on the uterus, on the muscle layer, you can take it out by a keyhole surgery. If there is other causes like endometriosis and adenomyosis, then you can start with laparoscopic treatment, and if it doesn't work, the treatment for adenomyosis is hysterectomy.
Thank you very much, Ms. Pandey. That was really interesting to
Sure.
hear about abnormal uterine bleeding.